Hi, it's Dr. Centeno, and thanks for watching. Today, you've got the power. Today, we're going to talk about an interesting topic first, and then, as usual, I'll answer any patient questions about any topic, not just the one I'm talking about. But we start with a topic to kind of get the dialogue going. So the topic today is THC use and really all surgical procedures, but in particular, how it can really impact procedures that require anesthesia, like the one we perform for craniocervical instability, the PICL procedure. Uh, and in particular, what's we've been noticing for many years now, because we're in, I believe, the first state to legalize recreational marijuana, is that our THC using patients have dramatically increased anesthesia requirements. And so, what that means on a practical basis is that if the patient would normally take, let's say, 4 milligrams of Versed, which is a Valium-like drug that's given IV to get to sleep, if they're a THC user on a daily basis, it takes 12 or something like that. Same thing with the use of narcotics during the procedure, etc. And last year, we actually had some anesthesiologists publish on this phenomenon because they're starting to see it as well. And what they noted is what we see, and that is that the increase in medications that it takes to get someone to sleep who is a THC user increases the overall risk for that particular procedure, because the more medications you have to use, the more potentially dangerous anesthesia becomes. And that's because you're always kind of on the edge between having someone asleep and not being able to support their own breathing. That's really that happy place that you want somebody, is kind of in the middle of that zone. But obviously, if you've got to use more and more medications to get them into that zone, the cliff gets higher and higher that you can fall off on to the other side. Now, obviously, if you're an experienced anesthesia provider, you're set up to handle all of those contingencies, but it doesn't change the fact that the risk still goes up. So you might ask, what's causing THC to increase this anesthesia requirement, to increase the amount of drugs it takes to get someone to sleep? And it's likely similar to other drugs, meaning that if you take a lot of narcotics, for example, your tolerance to narcotics and also anesthesia drugs is going to go way up. So it's probably the same phenomenon. It's probably upping the enzymes needed to get rid of all drugs out of your system. And consequently, you're chewing through these medications much more quickly than you normally would be. So again, if you're just joining us now, this is a topic that we'll talk about for a little while, and then we'll go into questions about anything, not only the topic at hand today, but really what I'm discussing is how we've noticed, and now it's been published in the peer-reviewed literature, that if you are a THC user, and especially a daily user, you're going to require much higher doses of anesthesia to get you to sleep. So I gave the example before of someone who might be asleep at 4 milligrams, given their size, of a drug called Versed, who takes 12 because they're a daily THC user. And no one's 100% sure why that's happening, but it's likely related to the fact that your body's enzymes that get rid of all toxins in the system are revved up, and you're chewing through these medications at a much, much higher rate than someone who doesn't use THC on a daily basis. So what does that mean if you've used THC and it's a great help to you? I'm not an anti-THC person at all. In fact, I voted for legalization here in Colorado, so I've got no real dog in that fight, so to speak. But what it does mean is that you're going to require more anesthesia. And when you require more anesthesia, that increases the risk of any procedure we perform. Now, listen, maybe you've tried lots of different things through the years. Maybe you've tried narcotics and this works better. That's all good. That's probably a better alternative to certainly than taking OxyContin. Having said that, you also need to know that there is an increased risk for anesthesia if that's how you're managing your symptoms or your pain. If you're taking THC for just things like anxiety or recreational use, I'd recommend that you get off of it prior to the procedure. And if we have problems, we'll let you know. So we saw a patient last week where we've had consistent problems. She hasn't yet stopped using THC, and it really increased the risk of her procedure enough where I had to have a conversation with her and say, we can't do this procedure again on you unless you're able to get off THC, because that's what happened. Now that's an individualized thing. It might happen in some people and not others. We may conclude in another patient, it's not that hard to get them asleep. It's in the safe zone. So if you want to stay on this stuff, that's fine. But you should be aware that this is an issue, and you should be aware that as far as your body is concerned, it doesn't know if it's OxyContin, THC, or something else. You're still going to need more anesthesia in order to get to the same place than you would if you didn't use THC. So that's my discussion on that. So realize that if you're thinking about doing the PICL procedure or any other procedure, even if it's surgery, you got to let the anesthesia people know that you do take THC, use it to manage your pain or whatever you use it for on a daily basis, because it will increase the risk of the anesthesia, and they need to know that so they can start off with some higher doses and understand why they're giving those higher doses, because that's really the key. It's one thing to say, well, this guy's taken 2 to 3x to get him or her to sleep. But it's another thing to say, okay, I know why that's happening. I know that there's not another problem I need to be looking at. It's probably their THC use. So with that said, I'll start taking some questions. Again, the questions here are about anything, not just the topic we're talking about today. So let me start with those questions. Eric, does THC slow the healing process? It's interesting, Eric. The only thing we've seen in the literature so far is that THC seems to push mesenchymal stem cells more towards bone than other tissues. So that's a potential problem. I can't say that's one that we've observed, but the in vitro, meaning lab data, suggests that. So it could, but no one's 100% sure yet. Realize that all this stuff is still pretty new. Colorado was the first state to legalize recreational. Hence, we've got the longest experience, but that's only even 5 or 6 years. So we're not talking about 30 years of experience with this, with tons and tons of publications. It's been advanced by Harry Winston. Does that include things like CBD products? You know, Harry, the answer is probably yes. So far, I've seen it mostly with high THC users, but I also believe I see it with CBD users as well. So it's probably similar between the two, but the current literature-based warning, the one that's now being studied, is THC. Submitted in advance by Jeff. If you've been using THC for years, would you go through side effects from stopping it? Yeah, Jeff, it is interesting. I do believe that THC is more medically addictive than it has been led on. Listen, THC, like everything, has established now its own industry. Its industry is pushing certain narratives. When it comes to being addictive like that, if you're a daily user, my sense is you will suffer some sort of withdrawal. Now, it's probably not going to be the shaking DT type withdrawal that alcoholics go through, but there's going to be some sense of withdrawal there, yes. So you're probably going to pay for it a bit. And again, it's not that well studied because this is a relatively new phenomenon. But I have seen patients who really have a hard time getting off THC. And again, I don't think they're going to go through the DTs where they're in cold sweats, but they're probably going to feel some effect from getting off THC. Eric, I had a local knocked out, put under for hemorrhoid surgery. Eric, not sure what you mean by that question. Maybe clarify for me. I'm not sure if you're asking about type of anesthesia here or just giving me information. So happy to answer any question that you have there. Any other questions I can answer today? Again, about any topic, not just this one. This is one I just decided to start with because we're seeing it more and more. And it's always good to make sure patients understand what's happening there. Oh, said you were smoking cannabis a few days earlier. Yeah, I don't know if they talked to you about that. Again, it's not every single patient that's using THC. It a lot depends on genetics plus that. We're getting up into those really high doses. I suspect if it took a really high dose to put you under, they probably would have talked to you about it, but maybe not. I don't know that particular area of medicine as I do this one. Daniel, any new data from PICL case study? Nothing new. We still have our team looking at all the research. We've still been working on that master list. I can tell you that there's no new insights from any of it right now. We are, so we'll continue to work that. Now, our research team is bogged down with a few other topics right now that they're working on, so they probably won't get to look at this again till likely this summer, and they'll start probably looking at some data at that juncture. But they've got lots and lots of different things to do, not just this stuff. Are there any supplements that you don't want to be on part of PICL? You know, I don't think there should be an issue. The only thing I can think of, well, let's go through some medications because I think that's a bigger issue. As far as medications are concerned, with any kind of bone marrow concentrate procedure, we don't like ACE inhibitors. Those are a certain kind of blood pressure drug because we've seen those cause issues in mesenchymal stem cells. Statin drugs aren't great, so those are cholesterol lowering drugs. We've again seen some research showing that statin drugs may be a problem for mesenchymal stem cells. We also don't want anyone to be on non-steroidal anti-inflammatory drugs like Motrin, Aleve, ibuprofen, Celebrex, that kind of stuff, because that can block the healing response that we're trying to initiate, which happens through acute inflammation. And narcotics can be an issue, not so much with the stem cells, but again, having to do with post-op pain control. In the same category as THC, low-dose naltrexone also seems to be an issue with pushing up anesthesia requirements. As far as supplements, there's none that are really prohibited at this point, but there is a pretty stout medication list that I just kind of quickly went through there. Submitted advance by Charlene. How far in advance would you need to stop? Literally, to get rid of this kind of effect, it's going to need to be 2 or 3 months before your procedure. Again, if you're not a heavy user, we won't struggle as much. But if you're the kind of user that's using this stuff every single day, we may struggle with your anesthesia. Now, that's increasing risk. The good news is the risk is already low, so tripling it is not making the risk extremely high. But obviously, we all try to control risk, and we want the risk to be as low as possible when we do these procedures. Eric, I talked to an anesthesiologist, special cocktail mix. Oh, gotcha. Yeah, you can give patients things like ketamine, as an example, which can cause some dissociation. So that can really help getting them to sleep or keeping them comfortable, even if they are slightly awake, because you can't get them to sleep because you're concerned about the high doses being used. But there are drugs you can give that'll help this effect. Levon, how much or how often such symptoms as headaches, insomnia, brain fog, fatigue, exhaustion, etc., have actually been caused by CCI from your clinical experience? Once treated for CCI, they were gone. Well, all I can tell you there is those are common symptoms of patients who have CCI. Let me see if I can pull up a blog I did on this because it may provide some good information to you. Let's see here. Sorry, guys, there. It's going to take just a second more. Okay, let me try to share my screen here next. Okay, so I have up on the screen the most common symptoms of CCI patients. The bigger the word, the more common the symptoms. So as you can see here, you've got your first level symptoms like headache, dizziness, lightheadedness. Then you get into things like numbness, tingling, neck pain. And then the third tier symptoms, cracking in the neck, fatigue. And then you've got fourth tier symptoms like cognitive issues, anxiety, GI problems, thoracic pain, brain fog, blurry vision, tinnitus, tachycardia, rapid heart rate, etc., and so on and so on. So the smaller the words, the least means it's less common to see those symptoms, and the bigger the words, it's more common. So the best I can tell you, and let me get out of that share here, is the best I can tell you is at the end of the day, those are the symptoms. Now, it depends on what causes those symptoms. CCI can cause those symptoms. The problem is there's overlap with other things that cause the same symptoms. So at the end of the day, I can tell you that if you have CCI causing those symptoms and we help your CCI, those symptoms will generally go away. But those symptoms can be caused by other problems too, so that needs to be worked up first. It's been advanced by Sherry. If you use THC regularly for pain, would you experience more pain from the procedure than normal because of stopping the THC? You might. I think the best strategy there might be to go off it before the procedure and then go back on it after the procedure, or use other things for your pain rather than THC that don't increase the anesthesia requirement quite as much. But you could theoretically go off of it for 2 months before and then go back on it for post-op pain management. Jennifer, do you see a number of patients develop dystonia secondary to CCI? It's not the most common thing out there, but I'm just looking at my list here that I just had up on the screen because I know dystonia is on here. So we have on here myoclonic jerking and spasm. And so the dystonia patients are probably in that category. What I would tell you, it's a fifth level symptom. So what that means is perhaps only 5 or 10%, maybe let's say 5% of patients would report that, but it's within the realm of things that are reported. Do you use prolotherapy for CCI injections? If so, how long will the treatment last? Yeah, Daniel, if you've got true CCI, we don't use prolotherapy. The reason we don't use prolotherapy is because we've got to inject the ligaments that hold the head on directly. And the only way to do that is from the front using this PICL procedure. Now, if you've got just CCI, a more rare subtype that's just related to some damage of the ligaments in the back, which is where prolotherapy tends to be done here in the back of the neck, then that's something that could be helped by those sorts of injections. So maybe 1 in 10 to 1 in 5 patients might get relief with that kind of approach, but most CCI patients would not. Brendan, an instance where posterior helps some, how do you determine if when to do PICL? Like, do you get new imaging to see if it's still bad? I'm in this situation. Yeah, Brendan, realize that the posterior, now I don't know which posterior injections you've had here, but at the end of the day, if the posterior isn't moving the needle substantially, and let's talk about what that looks like. So let's say someone gets a single posterior procedure. We inject the upper cervical facet joints under x-ray guidance with contrast. We put high-dose PRP in there. We do some PRP injections into the posterior ligaments, atlanto-occipital ligaments at the very top, which usually aren't injected by any place else really but us. And that you come back and you say, I'm 25% better. That has helped me. We might decide to do another posterior injection at that point, depending on how bad your CCI is. So if your CCI is in the moderate range, we might say, yeah, let's do that a second time. And let's say you come back and you say, well, I'm another 10% better. If you've got significant CCI at that point, we're probably going to tell you it's time to move on to the PICL procedure. Now that's to be compared to something else. Let's say you came back and you said you're 50% better, and the second time you're 75% better. In which case, we're probably not going to go to PICL at all. So you see how that works there. Donna Boyer, tell me about metformin you're taking where your sugar level is high, pre-diabetic. Yeah, hey, Donna. Yeah, my sugar levels weren't that high. I was being monitored for age management. So not in the pre-diabetic, but certainly in the hyperglycemic range, and probably had been my whole life. So that's one of the reasons I started taking it. The other reason I started taking it was because it's now been associated with anti-aging, and there's some pretty strong research on its anti-aging effect, even if given in people who are not pre-diabetic. So the evidence was strong enough, and there was some reason to take it anyway that I started on that, and it has made a tremendous difference for me. Now, I guess we'll see over the next 20 years if it makes any big difference. But I'm getting old like everybody else. Mike, do autoimmune diseases make stem cell injections less effective? We don't see that. I think the biggest thing that we would see is that if you have something like EDS, which is stretching ligaments, then it's certainly possible that it's going to take more treatments, all things considered, in that person to get them where they want to be versus someone who doesn't have that. So if that's what you're discussing, then yes, it moves the needle a bit. But if you're talking about things like dysautonomia, which is more of a symptom, or if you're talking about things like lupus, we don't have enough lupus patients in our PICL data set to really make that claim, but my guess is it may move the needle if you're talking about something like lupus. So you may want to put down specifically which autoimmune disease you're discussing. How about chroma? Not sure what you mean by that one. Jay, does having a greater amount of time between an initial injury and first PICL impact success of the procedure? Yeah, Jay, I would say the answer is probably going to be yes on that one, meaning that I would kind of put people into within the last 5 years and greater than the last 5 years. My guess is that if we break it down that way, we are going to see some effect of the patients who have had a problem like this for a very, very long time, 20 years, 30 years, etc. So not 100% sure on that one, but I would say my gut tells me it does have an impact. Well, how about Crohn's disease? Have you seen patients with Crohn's who still benefit injection therapy? Yeah, we've not seen any issues with any patient with Crohn's disease and any injection-based therapies. So if you're using a biologic drug, And as rheumatologists would define that, that's an anti-inflammatory biologic. Then yes, something like Humira, that could dramatically impact your response to an injection-based orthobiologic procedure. So I need to know more about which drug you're talking about, but that drug class in general, I do have concerns about for these procedures and with healing. Sion, can bulging in the upper neck disc cause cervical instability? I'm getting upper MRIs with flexion extension this week. It's not really a causal thing as much as it is if the disc is degenerated enough to allow a bulge to happen, then with decreased disc height, you can see more degenerative instability because of that. But the bulge itself, if there's good disc height, wouldn't really cause any instability. It's more just a symptom of a degenerative disc, and it depends on how degenerated the disc is. Floyd, what kind of movement should be avoided the week after PICL? Should we avoid moving head at all? No, Floyd, I always tell patients this is an activity is tolerated recovery. What you were doing before is what you should do after. Listen to your body. If you're very sore, do less. If you're not very sore, go back to your usual activities. So there's no reason not to move the head. Connor, hi, Centeno. When I move anything in my thoracic spine, I feel everything is so lax, but I've seen no benefit of 2 sessions of prolotherapy so far. Struggling to hold myself upright because everything feels very weak. If I lay on the floor and try any type of bridges or anything, I feel everything grind and clunk all the way down the spine. Is PRP more tightening than Prolo? Yeah, Connor, I don't know what's wrong with you there, meaning that you'd have to have a thoracic MRI and a really good half-hour hands-on physical exam to get to a diagnosis. So the possibilities would be that there's something moving around your thoracic spine that's not being injected because of the skill level of the provider. Also could be irritated thoracic spinal nerves, which we've seen a lot, and they're commonly underdiagnosed because the provider isn't doing the kind of hands-on exam that can find them, or the provider doesn't know how to read a thoracic MRI themselves. They're relying on what the radiologist said. So those are all potential issues as to why this isn't working. Obviously, there can also be pain coming from the thoracic facet joints, etc. So all of those are very specific treatments that require X-ray guidance, and in the thoracic spine, quite a bit of experience, meaning that like the upper cervical spine, although not quite as bad, if we take 100 interventional pain providers who have been trained to do interventional spine with X-ray guidance and contrast, only a couple are going to be even comfortable injecting the thoracic spine at all because the lung field is there, and even fewer are going to have had a lot of experience in injecting it. So you have to be really, really careful there to make sure the provider you're seeing understands all of those parts and pieces before we say one whole therapy type doesn't work. It may well be how it's being applied. It may well be it's not even the right therapy type for what you got going on. Thank you for the answer earlier. Can you explain the PICL procedure? Sure, Daniel. So if we have people watching who don't have CCI, craniocervical instability, you've probably never heard of PICL. So PICL is when we come from the front to inject the ligaments that hold the head on due to laxity in those ligaments that hold the head on, or what's called craniocervical instability, or CCI. When we do that, we put in a 3D printed mouthpiece. We have the patient asleep. We create a sterile field at the back of the throat using an endoscope. And then using X-ray guidance, we direct the needle into the ligaments that hold the head on, alar ligament, transverse ligament, accessory, and others. And then usually inject bone marrow concentrate to try to help those ligaments tighten or heal. So that's what the PICL procedure is. And it's what you'd want to do if you were thinking about an upper neck fusion surgery. And it would be the step between failed chiropractic physical therapy, injections, and a fusion surgery. Mike, are you aware of any correlation of CCI and what I'd call internal tremors? I think more CCI causing that kind of phenomenon than vice versa. I have alar and transverse ligament injuries, PICL, the way forward then to get the normal or posterior injections. Yes, Ian, the posterior injections can't reach those ligaments because the spinal cord is literally in the way. So they're not going to get injected if you come from back here. You have to come from the front to get to those ligaments. So if that's what you've got, then PICL would be the only procedure that actually directly focuses on those ligaments. Everything else is going to be unable to get to them. In order for these things to work, you obviously have to inject the ligaments that have issues. Jay, is it okay to pop your neck to relieve tension with CCI? I've heard conflicting answers on this topic before and whether it's good or bad for the neck. It's a really good question, Jay. I think if you've got mild instability, then some patients would say that a gentle pop in their neck can make them feel better because it feels like it goes back into place or shifts slightly so the proprioception is better. Now, if you've got more severe CCI, then a more aggressive pop like this kind of thing, trying to pop your neck, not a good idea. Nor would I'd recommend that even in mild CCI. More talking about the kind of thing where you maybe go like that and the neck pops and it feels better versus this kind of thing where you don't want to do that if you've got CCI at all. Mike, on the topic of thoracic herniations, I have small herniations at T3 and T4, T8 and T9. Can a herniation at any of these levels cause burning type pains below the shoulder blades and in the chest? Yeah, so Mike, that's exactly what I was just bringing up. Yes, so the answer is any or all of those levels can cause pain like that. And so in order to tie that issue to that problem, you would have to be able as a doctor to look at the thoracic MRI images yourself and interpret them, which kind of brings you down to maybe 1% of all providers who actually look at their own films these days. And then number two is you'd have to perform a complex hands-on exam to see if the nerve areas at those specific levels were having problems. And then the treatment for that is not prolotherapy, which is a ligament injection, but in our case, a platelet lysate transforaminal epidural, which is another problem because, again, if we take 100 experienced spine providers, probably only one or two have done that more than a few times in their entire career. And that's because the lung field is there. So for the most part in interventional spine, it's the neck and the low back. And there's this whole big thing in the middle called thoracic spine, which is often ignored. So that's sort of kind of the steps you'd want to go through to try to see what's up. Connor, ever since I developed CCI, my entire body fell apart. I have HEDS, but I never struggled with it my entire life. But it seems since my HEDS went unstable and set my entire body unstable head to toe, never felt anything like it. And I'm a very complex case, completely debilitated through instability body-wide alone. Do you think other things such as mold, Lyme, Bactinella, et cetera, can do this to an EDSer? I was bike riding 2 years ago and was functional. This happened overnight. I don't even know, I'm assuming, what caused it. Yeah, so Connor, I think the first question would be is, do you have CCI? If you do, then is it causing all of this? Now that's possible that it can cause all of this kind of issue in the entire body and complete disability. We have patients that are like that. But then the other question you've got to ask yourself is, are any of these other areas, have they taken on a life of their own? And do they need to be treated independently? Now, for an HEDS patient, that can be literally just an area being unstable and not being able to tolerate the extra pressure that comes from problems up here going down. So that's the kind of process that needs to be gone through to figure out how to help you. Again, can't guarantee that you can be fixed, but I can say that that's the kind of process that we would use to see if this is leading to all of that. Floyd, what is causing dizziness in the case of CCI patients, especially the spinning sensations? Yeah, so that's a great question. If you read the CCI book, which we can put, I can have Carol put in the show notes here. Basically, the CCI book goes through that. So what happens is that your body takes signals coming in from your eyes and your inner ear and your neck, and has to coordinate all three of those. And when those inputs are different, you can get dizzy. So the best example I've ever seen of that is someone on a boat. When they're above decks looking at the horizon and the horizon is slowly going up and down, most people don't get sick or seasick, but you go below decks and all of a sudden now you've got a mismatch. Your body is telling you that you're moving up and down through your inner ear, but your eyes are saying nothing's moving, so people get sick. It's the same kind of mismatch that happens here with the upper neck. If the upper neck gives abnormal information to the inner ear and eyes as to head position, then you can get dizzy. So usually, assuming that the other causes of dizziness have been ruled out, which would be things like inner ear dysfunction, usually the way to fix that is to treat the upper neck and normalize the input. So that's kind of the reason behind why people get dizziness-like symptoms with CCI or really any upper cervical injury. So yeah, do you have a direct email? When I get my results back, I want to see how many PICL procedures you think it would take to get back to normal. Any athletes have this procedure and go back to sport? Yes, Ian, better to reach out through the Centeno Schultz call center, and that call center can go ahead and get you set up for a telemedicine visit. That telemedicine visit, we would look at all of your images, we'd go through your history, we'd go through any treatments you've had, et cetera, and then we can say you're a candidate or not for this procedure, because that's the first thing, is we've got to accept you as a candidate for the procedure, and that's not everyone we look at. And then I can try to give you some estimates, but those are not going to be great estimates of how many procedures you'll need. So that's the process there. Mike, thank you for all the answers and insight. With that lysate epidural you mentioned in the thoracic spine, does it help with just symptom relief? Does it also heal the ligaments and surrounding structures that are causing the symptoms? Yeah, Mike, so we wouldn't use that alone. We would treat the ligaments and what's called degenerative instability to try to help the problem, while we also try to put the lysate, which can reduce swelling around the nerve, but also increase the blood supply around the nerve. So the goal is to try to make it better than it is, not only to reduce the symptoms, but to make it better than it is right now. So that's generally how that works. And just realize that again, thoracic radiculopathy, or a pissed off thoracic nerve, is probably one of the most underdiagnosed issues I see. It's amazing how many patients we found through the years with this issue that have just completely been missed. In fact, I'll tell you a quick story about a local gentleman who is a radio personality, and he was getting ready to end his life, preparing for it, because he had a lower thoracic radiculopathy. It was going into his stomach. He went to see the local university physicians who were board certified in pain management. They didn't do thoracic injections. They just did lumbars. They did some upper lumbars. That didn't help. He had seen a surgeon. They didn't even give him the time of day. They didn't know what was causing his abdominal pain, but it was a lower thoracic nerve wrapping around. A single platelet lysate epidural and ligament injections. He went back to work, never looked back. And that's how bad these things can get, and how often they're misdiagnosed by very experienced providers. This was simply a lower thoracic nerve at around T10 that was wrapping around into his upper abdomen. And he had gotten the $1 million workup, but was really getting ready to take a fatal dose of his OxyContin. Obviously, he didn't after we got it figured out and quickly diagnosed. But thoracic spine is one of those areas that's just a no man's land, and don't know why, but it is. Do you know Dr. Kirkor in London, Regenix? Is he a great provider? Yeah, sure, Connor. Dr. Kirkor can certainly help you in providing an evaluation to try to see what's happening. He does not perform, and nor does anyone else but our clinic in Colorado, the PICL procedure, where we inject those ligaments directly. But he may be able to help us some of this other stuff you're talking to me about. And if you're in the UK, he'd be a great place to start. Sean, I have multiple symptoms and was diagnosed with CCI and medullary kinking. Is this something that would help me? I think by medullary kinking, you mean perhaps cervical medullary syndrome. Could be. So Sean, I'd need to know more about your problems, and that's something we do through a telemedicine, and we would review all of that stuff to see whether or not this is a good fit for you. So I can't really make that diagnosis online, but I'm happy to take a look at all that stuff. Cian, what makes someone a candidate? I want surgery if I can get treated by the PICL. Yes, Cian, we've got to be able to, number one, identify the CCI. So let's talk about that for a second, because I think this is important. In making a diagnosis of CCI, we're actually more strict than many of the surgeons are. We require that you have imaging evidence of CCI, that you have a history that's consistent with how you got this, trauma, EDS, etc., that you have symptoms that are consistent with it, and that your response to treatment makes sense in the context of CCI. So that would be, I put on a collar, I feel great, I get an upper cervical adjustment, works for a day. I try physical therapy, I get worse. All of that would fit with CCI. The CCI book, yeah. So here's, so if you want to go ahead and grab that CCI book, you can here. You know, it's a great quick read. So I'd really recommend that you consider getting the book. You could probably read it in an evening, and it'll teach you a lot about what this issue is, the symptoms, why, when, where, the surgery, this procedure, other procedures, et cetera, et cetera. Sean, I have multiple neurological issues, pain, and was diagnosed with CCI, retroflex odontoid, medullary kinking. Would this be something that would help me? Yeah, Sean, as I said above, it would be better to do a telemedicine to see if this is the kind of thing that would be a good fit for you. I can't make that diagnosis off of that description. I can tell you that we have lots of patients like that we've treated, but each patient is different. We look at, obviously, the individual facts for that person. Okay, now I do have a 2 o'clock my time hard stop. So that'll give us about another 10 minutes to answer any other questions anyone might have out there. I'm happy to answer those questions if you got them. Cian, I tried everything. The collar helps. I had some stuff and done in Texas that has helped tighten muscles, but still getting symptoms from it. Thanks for letting me know, Cian. You know, hang in there. The good news is there are solutions out there. The problem, as you've probably seen, is trying to get the right diagnosis and get to the right providers. And I think that's the hard part with this diagnosis. So hang in there. There are solutions that are out there. Okay, guys, I think then I will start wrapping this up today. I'll also, if something comes up, happy to answer it, but let me start that process. So what we're talking about today was THC and surgical procedures. You know, THC can be a great adjunct to treat pain. Having said that, at the same time, it can also dramatically increase the need for medications during anesthesia. So this is something I want to let people know. And if THC is working great for you, then we may keep you on it. Or if we're having problem with anesthesia, we may ask you to get off of it. And a few more questions just came in, so I'll do those here. Mike, can you share some success stories of CCI patient who returned to relatively normal life? I often see with worse stories online, and it's daunting. Oh, sure, Mike. Yeah, we've, let's see, and these are off the top of my head, but early on, we treated a judo master. She owned her own dojo. Uh, Not sure if they're called dojos for judo, but what do I know? Martial arts. And went back to grappling after a single treatment. She was trauma caused CCI a couple of years out, was really, really struggling, basically putting her grappling responsibilities, that's what they call when they do their head to head matches, onto others because it would give her a severe headache. So that's a good one that went back to usual activities. On the other end of that spectrum, a Canadian chiropractor who needed to lay down, I think I've told this story multiple times, lay down all but an hour a day, so 23 hours a day horizontal, who got that reversed and only had to spend 4 15-minute periods during the day lying down and went back to work. So we definitely have lots of stories like that. We obviously tend to focus on some of our patients who are very, very disabled. And obviously, the more disabled you are, the less likely it is, I think, you're going to get back to normal physical activities. Connor, when I turn anything or bend or breathe, everything cracks, crevices, severe to me. I don't see many complaints about this. Yeah, Connor, that could just be EDS-related instability in multiple areas. So you may want to, again, get that checked through Dr. Kirkor to see if he can focus on specific areas that need to be treated. Floyd B, is a small contour pillow and back sleeping a good idea? Yeah, that really depends on the patient. It's very patient specific. I've got patients that swear by a specific pillow. I've got patients that have never been able to find any pillow that makes them feel more comfortable when they lay down. So if you've got one that makes you feel comfortable, I'd stick with it. Brendan, I'm worried about putting off PICL for too long. I'm assuming if I have alar damage, it can worsen over time. Yeah, Brendan, we had a natural experiment there called COVID, right? When the world got shut down due to COVID, we had patients who were scheduled in for a second or third procedure who couldn't make it or wanted to stay home. And so we got to see what happens if you don't just continue. Now, obviously, we have patients, about 1 in 5, that are one and done. This wasn't them. These are the folks that need more than one procedure. And what we found was about half seemed to do just fine and be able to pick it up where they left off, and the other half seemed to backslide. And I suspect that the patients that did backslide are those that had more severe issues and probably less healing with each procedure. So it's hard to tell which one of those you would be in, but we definitely saw that with COVID. Levon, when I'm upright, I have very minor headache, whereas when I'm supine, intensive headache increases. Most severe headaches are after a long night's sleep. Could this be caused by CCI? Yeah, that could be certainly caused by CCI. It also could be caused by arthritic joints in the upper neck. So in that case, those joints might be in a bad position when you're laying down and getting more pressure put on them. But that certainly sounds credible, like it could be CCI, and you would want to get worked up for that. So that's either an upright MRI or DMX to try to see whether or not there's excessive motion there where the head meets the neck. Okay, guys, well, I am coming up against that stop time now. So I am going to, if there's any other questions that come in after this, I'll have Carol apply those to the Friday session. We will be here on Friday. We're now broadcasting on all 3 channels, the YouTube channel, as well as the 2 different Facebook channels, the Centeno Schultz Clinic and Regenix. On Friday, we'll have a topic that's going to be more generic. On Monday, we tend to do CCI topics. On Fridays, we do more generic topics. But at any time, you can ask any question. So if you are a CCI patient, you're welcome to get some questions answered on Friday. If you've got other issues and problems, again, at any time, just ask those. So again, just to sort of wrap up from where we are here and what we talked about, at the end of the day, what we saw is that, and what we've been seeing is that THC tends to increase anesthesia requirements. If that's a problem, we will tell you, and that we might ask you to get off of it because it's really increasing the risk of the procedure, because everyone wants to keep that risk as low as possible. For other patients, doesn't seem to be an issue, but the research is out there showing that it is a potential problem in increasing the requirements and the dosing for anesthesia that you'll need to get to sleep. So just want to make sure everyone knows that. Thanks for all the great questions today. If you've asked a question after this, then we'll have Carol copy that over to Friday. So check out the video for Friday. And again, you've got the power. You've got the power to help yourself, and you've got the power to get educated. So that's what these shows are all about. And an educated patient is a patient that gets better quicker, and a patient that knows what's going on. And so that's the goal of these shows, is to try to make sure that everyone gets educated, everyone's on the same page, everyone gets a chance to answer questions, and everyone gets one-on-one FaceTime with the doctor, even outside the office. So thanks so much for watching, and have a great day.